Welcome. My name is Steve Eck, and I'll be introducing today's Modern Healthcare Custom Webinar. We'd first like to thank our sponsor, Laerdal Medical. A few quick housekeeping notes before we get started. All attendees will be muted to minimize background noise. We will reserve 15 minutes for audience questions at the end, but please use the Q&A function to pose your questions throughout the webinar. Recordings will be emailed after the webinar. Please watch for several free resources that will be available to you. They'll be announced during the webinar. I'm thrilled to introduce our session sponsor and moderator for today's webinar, Andrew Christopik, Content Marketing Manager with Laerdal Medical. Now it's my pleasure to turn it over to Andrew to begin the presentation. Andrew, the floor is yours.
Thank you very much, Steve. Welcome, everyone. If you're joining us and you're new to Laerdal, our mission is helping save lives. We pursue that mission by bringing you best-in-class patient simulators, expert written scenarios, and faculty development services. We're also able to conduct simulations on site for you on your behalf. So if you're joining us today from a hospital, nursing school, or PA program, a pre-hospital program, and certainly our military, welcome. We're glad you're here, and we hope you enjoy the following program. Our title today for our webinar is Explore, Expose, and Promote Equitable Care Through Patient Simulation. And with that, I'd like to welcome our guest speaker, Dr. Desiree Diaz, who is the Associate Professor of the Department of Nursing Practice for the College of Nursing at the University of Central Florida. Desiree, welcome. So glad to have you here today. It's really a privilege. Welcome aboard.
Thank you. I extend greetings from my office to yours. So I'm excited to have a conversation with all of us online today.
We thought you'd like to just give a shout out to all your colleagues down at the University of Central Florida College of Nursing.
So plug intended is what you're saying, Andrew.
Sure, go for it. Yep.
Welcome from the College of Nursing at Orlando. I cannot say sunny Orlando today. It is freezing 52 degrees. That's Floridian freezing. So I'm sorry if you have snow and need to bundle up. But we are a large urban university. We have a simulation technology and modeling center where we do state-of-the-art research in simulation in the clinical setting as well as up in the lab. So again, we are excited and privileged to be here with you today.
Very good. So we're going to begin, before we jump into all our content for today, we're going to begin with a polling question. And you'll see that polling question pop up on your screen in just a moment.
Ooh.
And I, of course, am not seeing the polling questions. So
I can see the polling question.
So I'll tell you what. So why don't you please read the polling question to everybody, Desiree?
All right, perfect. So it's a quick poll. What do you think prevents us from dealing with implicit bias in healthcare? Select only one answer. The A, or number one, would be the issue has become too politicized. B, people can't fathom that it even happens. C, people want to put race or ethnicity behind us. D, many fear violating laws about protected classes. And E, all of the above. Now, as a reminder, Andrew and I will not poll, neither will the organizers. So it is truly from you, the audience.
So very good. So I'm just experiencing just a little technical difficulty here, so I'm just going to have to squint a little bit. So yes, this is live. So what we're seeing here is all of the above, and that's interesting. So no one's really zeroing in on one thing so far. Are you surprised by the results you're seeing, Desiree?
No, I'm not. I think it's all intricate circles that join together to create, whether it be a problem or the ability to discuss these issues, and it comes to light right here because it's not just one thing that prevents us from dealing with it, let
Sure.
alone in healthcare.
Sure, absolutely. So let's go to the next section here. So this is sort of the cornerstone. What is implicit bias, and can you help us understand what that is in a way that it takes sort of the guilt out of it? Because I think that's how most people would feel if they discovered that they did have an underlying implicit bias towards an ethnicity or towards a particular group. So help us understand what an implicit bias really is.
Sure. So first I need to start in simulation terms. This is a safe environment for you, the participant, as well as for me. So the views I'm going to share here are mine, not associated with anyone else. No one's giving me anything to say something specific. That's number one. Number two, it's really important for us to be open and honest about how we really feel, because that's how we're going to get deeper into implicit bias. So there are things that inherently we are biased to. We were raised in whatever our home environment was, whatever our town environment was, and that creates inherent bias within us. Now, sometimes we're unaware of these things. The key is not whether you're aware or unaware. It's what do you do with the information once you realize that you do have an implicit bias? And that's the key I think we have to focus on. You know, Andrew, you and I have talked at length about this, because I think you can go down a rabbit hole of, oh, I don't have implicit bias. That test wasn't valid. You know, I don't agree with that. That's great if you don't agree. But can you go on the assumption that maybe there is some truth? Maybe you don't agree with it 100%. And then what do you do with that information? You know, it could be some things like Andrew happens to be Italian. My bias might be that, wow, does your grandma do all the cooking and make all homemade pastas for the holidays? Now, you might think, well, that's not really a bias, but isn't it? What if there aren't any females and Andrew's doing the cooking for the holidays? Am I then negating his stature, his place within his family? That am I buying into a stereotype that only women cook and only the older women, and that Italians only eat Italian food? So it's those types of things where we need to bring it to light. I don't know.
So I'm smiling because before the call, for the benefit of everyone, we were talking about holiday food, and so I mentioned that everyone's put in an order for lasagna for Christmas Eve. Well, I'm sorry to say I don't have an ounce of Italian in me. So there you go. So, and I think you're going to give me
better, Andrew.
You're going to give me a zinger later on. I know you are. It's teed up. So thank you for explaining that for us. So let's move to now. How does implicit bias impact patients?
Okay. Well, we can start with, I'll call them the elephants in the room, right? We
Sure.
hear that certain cultures are more stoic than others. For example, we're taught in a lot of medical education, and when I say medical, I'm saying broadly, whether it be actual medicine, nursing, social work, public health, whatever, that maybe Germans are more stoic. And in the studies that they've done, German patients may not ask for pain management. Doesn't mean they're not in pain, but they're not going to say that they're in pain. Now, if I go into that thinking that, my treatment or my intervention options for that patient may differ. I'm bringing that thought into my care of the patient, which means I may not even ask them if they would like something for pain. I might do an assessment, but not offer other interventions that could promote healing and decrease pain. Now, when we look at something like pain management, it's not just the treatment options, it's also in the method and the mode of delivery of what you're doing. So maybe I offer you just repositioning or distraction therapies rather than medications, which then brings me into a different bias from a different culture. We think that culture X are prone to being drug seeking, the bad words in healthcare, right? So we don't offer them pain management every 4 hours as we could. We offer them the pain management related to medication, and then we move on to something else. Let me put on that TV for you. Do you have someone you can call? And do other things. So it really does affect outcomes because our interventions are or may not be as adequate as they could be.
And we'll come to something shortly when we examine a particular patient case. Handoffs, right? And handoffs are one of the most dangerous places for a patient, because what gets diagnosed or what gets assumed, what gets tagged to a patient early on certainly gets passed on to the patient as they move through the system. So thank you for covering that for us. And here are just some statistics. And these came to light first through some studies, data coming out of originally Louisiana, but that's not the only place. But this is what made the news and really got people dialing in to this problem. Black mothers 3 times more likely to die from pregnancy complications in the US. And here's another statistic, a sad one. Black expectant and new mothers often undertreated for pain. These are stories that are making headlines. And then of course, there's other data here, and we won't go through every single one, but we have issues with people not necessarily being educated about the healthcare system, about their health, maybe not engaging in health. And then of course we have issues when people are coming into the healthcare system itself. I don't know if there's any statistics here on the screen that you'd like to comment on, but certainly these are available for everybody to see right now.
Well, I think one of the important parts of this slide when you share it isn't just the statistics. It is what makes those statistics a number on our screen and what can we do collectively to change them. So
Sure.
Some, yes, is education and stereotypes. Some of them are systemic issues within, whether it be clinic settings, hospital settings. Some are related to community environments, and really looking at different social determinants of health, different socioeconomic factors that actually affect a person's care. And I think that is the takeaway from here. Why is it that 41% of Latinos lack basic health literacy? Where are they getting their information? Are we teaching it in schools? It's not, I don't want us, Andrew, just to look at it as one little silo. It's a bigger, more complex problem, and we all have a part to play in that. Are we providing information in other languages? Is it the same language? We are a melting pot, whether it's acknowledged or not, which means we need things in multiple languages and multiple resources.
So you just teed up, that's a beautiful segue to our next topic, which is another pillar of understanding disparities that are occurring in our healthcare system, and that's the topic of cultural humility. So we began with implicit bias. Now the other side of the coin to get us out of the implicit bias trap. What is cultural humility?
I believe that cultural humility is not believing that there's one expert in any one culture. It's not one voice that speaks for the collective. It is each individual person is that an individual. So if you just take where we're all living today in the United States of America, if I said, well, what is the culture of America, or you're American. What does that mean for you for the holidays? Well, that's so out of context because there's other factors that influence and affect that. No different than if you were away on vacation in a foreign country and someone asked, oh, are all Americans like X, Y, and Z? It's the same thing for other cultures. The humility aspect of it is, think about you, and I'm talking to you, the audience. Think about your culture. What's important to you? We have holidays coming up, whether it's Hanukkah, Kwanzaa, Christmas, New Year's, whatever that is. What does your family do? Take a minute, think about that. Now, let me ask you, does every family in your culture do that? And can you be 100% sure that they do? I can tell you for me, the answer is no. When I talk to colleagues in my office, they're very different than me. We may have both been born in America, but the influences on what we do and how we act are very different. And the humility piece of that is understanding that, valuing it, and realizing it impacts every aspect of life. So when, Andrew and I have been talking about baking and food prior to this conversation, and think about it. When you go to a restaurant, are you quick to eat, get up and go and move out? Or do you sit there and saunter and engage in conversation with the family? Is it based on your family? Or is it based on your culture? From the islands, people always talk about island time. It is about people and food and community. So you're not going there to do anything quickly. And it's not because we're slow, we're lazy, we're enjoying the moment. So I think that's one piece of cultural humility.
So we're going to go to a couple cases in just a few minutes, but you mentioned something that's especially important, and that's the attitudes towards family, the attitudes towards togetherness and so forth, that does overflow in terms of care, providing care to someone holistically. And to the point of Christmas Eve, we have, at our gathering, it is going to be a cultural melting pot with a lot of very different competing interests. So maybe if we have time, we'll share more of that later. So let's go to why simulation, before we continue with some cases, why does simulation give healthcare providers an edge in this arena versus other ways of trying to solve the problem?
I think that's a valuable question and context. And for our viewers watching, we can't put an amount associated with context. Providing context for someone is more than just here's a book, here's a SOP or standing operating procedure, or here's something in a binder. It's letting them embrace the situation around them. And simulation allows us to do that in all aspects. It's kinesthetic, so what are they touching? That includes audio, what sounds are going off, and now we're pulling in another aspect, the human that's in the bed. Now, all of that is really important, and we can standardize it for all of our learners. Now, when I say learners, I mean whether you're in the hospital setting and it's your nurses, your doctors, your respiratory therapists, or in academia, it's your undergrad, your grad, it doesn't matter. You have to understand not everyone is exposed to an eclectic environment. But yet we are thrusting them in to healthcare, which number one, we know is eclectic, not just with the patient in the bed, but your coworkers. Number two, a lot of that with COVID, we're going telehealth. So how can I communicate with you via the computer and make you feel like we're having a conversation? So let me ask you, and I'm going to do my unstandardized polling question that Andrew doesn't know about. If I start doing this and I'm just talking to you about simulation, do you feel as engaged as when I'm talking to you? I'm looking at you. I'm relating what I feel. And as you can tell, I get all passionate and start talking louder and zooming in onto the phone. That's all in love. That is part of my culture. Now, Moving that into simulation, if we don't provide environments where practitioners, care providers can practice that, how do we expect them to engage? How do we expect them to go from typing on their computer over here on their phone to this? Isn't it different when I say to you, I am so sorry if any of you have experienced loss to COVID? My heart goes out to you. I experienced that loss this week from an aunt. Today's actually her birthday, so shout out to Aunt Pat, heavenly up there. But there's a different connection than if I just go over here and write it in chat. But how are we training our providers and professionals to do with that? I don't know about you, wherever you are in your office, how long it took you to get there. It took me, I've been a nurse 26 years and yes, an educator within that. But 26 years ago, we weren't talking about telehealth. We weren't talking about using mannequins and simulators to enhance our education. And no longer is OJT or on-the-job training acceptable in healthcare. So you ask a very loaded question, Andrew, because I get very passionate about that, because simulation is the key and it truly is the future in all settings. So I'm sorry I went on a little.
No, thank you. So we're going to get to talk a little bit about your aunt in just a moment. We're going to go next to a polling question.
Okay.
And
I'll read them just in
it
case.
is possible that you might have to read again. So.
Okay, quick poll. So from your device, log in quickly. From your own experience, where do you believe that observed racial and ethnic disparities in healthcare come from the most? Is it race, ethnicity, race and ethnicity, socioeconomic position, or is it a combination of all of these?
And you'll have to please also share the
results. No problem.
Share the results, yeah.
As a reminder, Andrew and I don't vote. All right. So again, everyone, you all think it's a combination of all of these. So we had 0 people, which I want to sit here for a minute, Andrew, before we advance.
Sure.
0 people said it was ethnicity. 3% said race, 7 race and ethnicity, and 8% socioeconomic. Now, I think it's a very interesting situation we have here, because I think, actually, I know in the United States, people get very confused with what is race and ethnicity. Race is not Hispanic, but yet we see that. Hispanic is ethnicity. Race, according to the US Census, there's 5. You'll generally see white, black, Asian, Native American, and other. Sometimes they put Pacific Islander also. And then there's this ethnicity piece. So, and the only ethnicity they ask ever is Hispanic, yes or no. So that's very interesting related to that. And then when you look at socioeconomic position, we'll explore that a little bit more as well. Okay.
So hopefully we're back and we're sharing properly. If not, I'm sure I'll get a message in just a moment. But hopefully everybody is seeing.
Yes, they're seeing me up close and personal.
This wonderful photo here. It's awesome. It's a great photo. So why don't you lead us through this exercise here?
Okay. So what I'm going to ask you to do, audience out there, is to close your eyes, quickly open up your eyes. You see this picture. Now, what do you see? What are the first 2 things that come to your mind? Well,
hopefully people are writing that down.
I don't know. I can't see if they're writing it down, but I'm telepathically thinking what you're saying.
Sure.
I don't know. It's a picture. Beautiful smile, great glasses, nice silver hair. I don't know. I could continue to compliment myself there all the time. But do you see the person? Can you see the person in the background taking the photo? How many of you zoomed in and noticed that person? It should make you think, ooh, okay, there are things there that I didn't see before. Did it
We're seeing some
require
great
you?
things coming across. I'm so sorry, I didn't mean to interrupt, Desiree, but we're seeing some nice nice things coming across the screen, and happy and joyful. I would agree, absolutely.
Okay, well, I can't see those, so
Sure.
thank you. So when we start to look at seeing what do you see, keep those thoughts in mind as we go through this little exercise that we've implemented in here for you. Go ahead, advance, please.
You bet.
So what I see here in this picture is a big question mark. So this is something that you have to have some cultural humility. Did you see an Afro-Caribbean woman? Did you say, wait a minute, she's not Afro-Caribbean? Well, actually, yes, I am. I was born in the United States, but my dad's from St. Martin on the French side. Very important if you're West Indian to know it's the French side. And my mom's from Guyana. This picture is taken back home in St. Martin. We were born and raised in the US, but we lived in St. Martin for a period of time. That's my favorite tree. It's a flamboyant tree. It's inherent in me. My office, well, you guys probably can't see it, but it's orange. It's everywhere. Okay. But now dig a little deeper. What does that mean? Did you come up with any of those things? Would you have said, well, why do you say Afro-Caribbean? Well, if I said black with the capital B being totally respectful, because I don't think we're crayons and colors of black and white, so I prefer to use a capital B. Do you know how the United States Census and that definition is termed and what it means? It means any descent from an origin prior to coming to the United States, so think about St. Martin and Guyana.
Sure.
That is of African descent. So yes, I would be black. I usually say they're black or Afro-Caribbean because then I get that question mark. You know, there, if they have the furrow, I mean, I'm trying to embrace that lovely line in my head. The furrow, they're like, no, I didn't see that. So let me ask you, let's go back to implicit bias. Is the furrow in your head because I don't meet your stereotype? I don't meet what you were raised to think of. What does Afro-Caribbean or what does black mean? Did you think when you logged on to this webinar today that Diaz would have been a Hispanic female? I am by no means bilingual. I am married to a linguist for 30 years who is, his first language is Spanish, and all of that is great, but it's not my first language. You don't want me in a court of law trying to represent you in Spanish because you probably would not have a good outcome. Do I know enough to get by? The answer to that is probably.
So I'm sorry, I didn't mean to interrupt.
No,
I apologize, but I wanted to also ask you to please comment on the. Let's go back to that family factor for a moment and social expectations because of how they affect the patient. And I have some experience with this myself. Cultures that are not used to, well, the type of independence that frankly many Americans are used to. So in other words, care decisions in a hospital, especially in the world of COVID. And I know you've got a story to tell here, but someone put into the hospital who is used to family being part of care decisions, family being part of the care process, possibly even diet being part of the care process. There are ethnicities that pursue holistic medicine differently than others or more passionately. So if you do want to share your experience with your aunt, by all means, but I think this does certainly impact how people may feel in the hospital if suddenly they're isolated, right? And that's not part of their culture.
Well, I think let's go some. I feel like I'm in a sim now, so hold that thought. Let me go somewhere and come back.
Sure.
So related to this process of who the person is, why is that important? It is important, like Andrew said, because we have patients that are isolated in the hospital, right? COVID, they're by themselves, we're limiting admission, but Say I'm the provider. That's not a big deal for me. I'm an only child. I like to be alone. My culture isn't really, I don't have extended family. I potentially am not thinking that the person in the bed is struggling, having a hard time, because they are in an environment on a daily basis with all of their family, even on the telephones. So how can we expose the healthcare providers to that? Well, if you had a simulation with a simulator in the bed hooked up with all the tubes or whatever, but then you had family in the room asking poignant questions to you while you're trying to care, that is not a skill that you can just develop on the fly. It can be, if you're a new graduate of whatever program, very intimidating. So providing the context for a new graduate in a facility, how does a new doc, a resident, talk to a nurse, whether it be a veteran nurse or a new grad, at the bedside with the family asking all kinds of questions, but maybe the provider doesn't know all the details. How do you gingerly say, all right, let's take this outside? If we don't provide them a framework and a setting for them to actually practice that. Think about the last time you had an argument with somebody or a major disagreement. You verbalized what you needed to say. You had no problem holding it back, or maybe you did it and you held it all in. But then what changed future behavior for that next encounter? So can we provide that in a simulated environment for practitioners to interact together before we get into the situation we're at the bedside? Now, pulling that back through and circling back to COVID, it is unfortunate that my great aunt did pass. She's spicy, spunky, Caribbean Guyanese woman, ready for the world. Now, she happened to be intubated and then extubated. And when she came to, one of her first questions was, number one, where is everybody and who put me here? Because the expectation in our family is that you're not going to a nursing home. You're not going to be anywhere by yourself. So maybe I go out and I'm in a coma, I'm intubated. I don't necessarily know what immediately preceded that. But now I wake up, I'm isolated. I'm in a room by myself, outside of the surroundings and everything medically we know. It was that family culture piece. So sure. I think that is one of the key things we could learn in this day and age with the global pandemic as to how do we provide training and context and circumstances. And the answer to that is the use of simulation. And I think the use of simulation also goes just beyond a simulator. It can be actually practicing. How do you communicate with a family member on the telephone when all you have is a telephone and you need to try to get a DNR or do not resuscitate, or, okay, this is how grave it is. Family on the other side of that are expecting us to relay in their context, not what your context is. We're expecting information coming from our perspective as what we should do next for care.
Sure. Thank you. And thank you for sharing your story. I'm going to ask you please to share another story, because you've got your own personal story here. And I also just want to do a quick comment to those joining us today. Please do, we've got some great questions lining up, and we are going to reserve time towards the end in about 15 minutes. So please keep the questions coming, because we're going to make an attempt to get to everyone. So your own personal experience, can you tell us a little bit about this?
So remember, for those who might have hopped on our call, this is a safe environment for me to share with you my shortcomings, my implicit bias, my ability to share is inherent in me. You know, we can talk about all of that for another day, because we always have stories as West Indians, and that means I like to teach via narrative pedagogy, via a story. So this is a story that actually took place about 2 weeks ago, I think, Andrew, right? I told you I was in clinic and a woman came in. Now, kidney function tests are based on, it literally says African-American, your estimated filtration rate or GFR is one thing, or if it says non-African American is another. So you base what level of kidney disease you have by that number. Well, I'm in clinic and a female patient came in who was dark. Her skin tone was dark. Now, I typically ask in clinical, so how do you self-identify? Do I identify as African American or non? I try not to make the assumption. And she said, no, I'm not African American. And I probably had the furrow on my head. So, you know, I was typing. And then, but in my head, I'm like, this lady is dark, like dark. So I'm like, oh, okay, well, where are you from? And she said, Georgia. And I was like, okay, now I really want this woman to identify, because I'm like, no, she's African American going off of my previous knowledge and my bias. And I said, well, where are your grandparents from? And she said, oh, we're Navajo Indian. And I was like, oh, so hence this, you know, being the pinnacle and on top, this person, if I went by solely her characteristics, not assuming that there could be something else underlying there. Now, all I simply had to do was ask, because that's what I tell people all the time, just ask. But my bias is believe the patient.
Sure.
Believe the patient when you ask. Just like when I said Afro-Caribbean, and this is the beauty of having a safe place to have this conversation. I asked, I answered, right? I said Afro-Caribbean. But did you believe me? Or did you make me quantify? Now, we didn't go on that exercise here. So once she said Navajo, I was like, okay, all right, you know, and then I went on. And then the next caveat is I explained that, well, when you are being asked that question, it's because of these two lab numbers that differ. Let them know why you're asking versus being invasive.
Sure. So how do we teach people to ask?
You know, being comfortable with being uncomfortable is where we need to get in the United States, and generally all over, truly, is it is okay to ask, but then explain why you're asking. The problems arise when we make those assumptions.
And I think this goes back to the very first polling question. I think that it's difficult because many of us don't want to, have been educated not to. But your point is well taken, and certainly something that should be incorporated into a simulation. And we're going to turn now to another personal story, and then we're going to get to a simulation in a moment. So if you could just spend a moment telling us about this photo.
And by the way, I think I said before, I have total permission to be sharing the
Sure.
photos and the stories that I am sharing here today. And that is also important. When you're doing participatory research or participatory outreach, you need to make sure the people you're using as exemplars and stories are comfortable, number one, and number two, they give you permission. So this is actually my grandpa and my aunt. This is Aunt Lynn, actually. When it was just a year ago, she was intubated in the ICU pre-COVID, so no COVID issues. They couldn't understand what was going on with her. They assumed she was Hispanic, which she's not. Both of her parents are from St. Martin on the French side, West Indian through and through. Come to find out, Aunt Lynn was on an ACE inhibitor. So for non-medical people, it's a heart medication or a blood pressure medication that is to be used in caution with Black or African American patients because it has an increased risk of angioedema. So they placed Aunt Lynn on this medication, not thinking that there could potentially be an issue. And lo and behold, she ended up having the allergy of, we'll call it an allergy, or the reaction of angioedema, intubated in the ICU for a week. Yes, they did take her off, but subsequently, we all passed it through the family. Hey, make sure we don't go on these ACE inhibitors because genetically our makeup is Black, and we've had these reactions. So when I'm talking about implicit bias, it's those things that you don't realize. No one might have thought, looked at her, okay, she looks Hispanic, but she's not. Could they have asked? So
There you go.
that there is just food for thought, which then we go into kind of segue into our next slide here. So
which I know I'm going to pay a price on.
So we have 3 glasses of milk here. Now, what I want you to do in the audience and for our viewers, I want you to look specifically at each glass of milk. Okay, so I'll give you a second to look at each glass of milk. Now, what I want to know is if you were allergic to chocolate syrup, which glass would you be able to drink from? Andrew, what glass would you be able to drink from?
If I was allergic to chocolate syrup.
Yes.
So I'm going to say the first one.
Okay. Well, unfortunately, Andrew,
I know I'm wrong.
We would then have you in probably the ICU intubated with an anaphylactic reaction, because the point and illustration of this is that glass actually has 1 drop of chocolate syrup already in there. But you can't see because the outside doesn't look like it. Aunt Lynn doesn't look like she's super dark, or I don't look like I'm super dark, but it's in there. You don't know what's under the skin of the patient. Now, you clearly could say, well, definitely not the last glass. You can make the assumption that that last glass you can't. Maybe the middle glass you're going to ask, is this chocolate milk? But the first glass is where we need to concern ourselves in certain situations, because we're not asking the question. And that changes patient care, patient outcomes. It's the same thing pulling that into patient care related to linguistic ability. That is the same thing as race and ethnicity. Just because it seems like I'm speaking good English, do I have a background in another language that I could understand healthcare information differently, better in my first language? So that's just some food for thought I like to throw in there.
It's a great exercise, and thank you. So we only have a few more minutes before we get into some questions. Let's have you lead us through this.
So we're going to go through a simulation real quick.
Yep.
We're going to call this our truncated Diaz simulation right now. So this patient right here enters the emergency room. Quickly, tell me, what do you see out there? What do you see? Andrew, what are you seeing? Don't answer that realistically, because I know you know this question or not. So if you look closer to this picture, someone had said, oh, is it a homeless person, disheveled? There's holes in this hoodie or not? But as my social worker colleague said when I sent her this picture, she's like, well, if you look closer, so let's look closer. You see actually a clean shaven man. You see a whistle around the neck. Makes me think maybe they're active, they're outside, they're exercising. But what was your initial thought? That's where we need to get at. Not what you eventually learned, but we change what our initial thought is. So change that.
Because it can affect this.
Correct.
So what and this goes to the point of handoffs, and I apologize, but I think that it's a point worth making, that it's not just when the patient enters the hospital, but the assumptions made will follow the hospital. Follow the patient throughout the hospital, and could even grow in proportion. So I hand it back over to you, Desiree.
That was a beautiful handoff, Andrew. So now we have this person who was in the ED. We've addressed the assumptions. Let's bring you into the simulation. Here now we have Mr. Richardson lying in that bed. How is our care going to change based on what we thought and based on what I'm giving you in report? It's very different if I say, here's Mr. Richardson, he's a 75-year-old man from the Caribbean, and he was found under the bridge, and he's here because he has some hypertension. Now, we didn't say he was found under the bridge with his hunting truck and it was broken down. We just said a simple fact. But that words mean things, and
Sure.
words mean a lot, and being more specific. So in this simulated environment, we're allowed to now recreate Mr. Richardson. We are able to pull in the moulage and have family things around him. This could be a long-term care facility. Let's talk about family and what does that mean? How do we get him to thrive? The elderly is no different than children with failure to thrive. If they're not engaged, if they don't feel needed and wanted. So how can we do that here? And that does change our health outcomes. That also changes our readmission rate, right, Andrew? Let's
absolutely
be real about it. So when we look at this person, if you go to the next slide.
And I just want to say that, so we've gone from patient example to now a simulator in what everyone's seeing here to
that was my dad, Mr. Richardson.
Meet your dad.
My dad. He is here with a baby simulator. So he's a jokester like me, likes to take pictures and say he's had a new grandchild. But realizing that if you put a person behind your simulated experiences, it then becomes real. It is a real story. It is a real person. Now, part of that, and if you understand me and my culture after this last hour, you know everything I do, my tribe comes with. This is my father actually upstairs in our simulation lab, because he's going to know where his girl child works. It's not about dad. We don't bring parents to work day. That wasn't an option. So it's the same type of thing that happens in the hospital. Well, how does that happen in simulation? Our students specifically don't know how to deal with stressors within their environment. They know how to look at the IV, look at the patient, look at the labs, but not answer somebody else's question. So I think we go back to providing context for all people and providers, whether it be in academia or the healthcare setting.
Excellent. So we've just got 2 more slides, and we'll certainly be quick because we do want to get to these questions. Why is implicit bias occurring in healthcare? People don't wake up in the morning thinking or saying to themselves, I'm going to exhibit this to my patients. So why is it occurring?
You said it, because people don't wake up thinking they're experiencing it. I mean, if we're all altruistic, most people going into the healthcare professions are altruistic. They're going in to try to help people. They don't believe that they potentially have an implicit bias of anything. So therefore it goes unchecked, unreferenced, unreflected upon. One of the key things that we can all do is reflect on experiences. What were our actions? Do a plus delta with yourself.
Sure.
What was good about that reaction? What wasn't? And what can I change for next time? And really reflecting upon the implicit bias, or what could be conceived as an implicit bias.
Excellent. Thank you for that. And last but not least, softball. Who needs to be? It is. Who needs to be involved in these types of simulations?
If I can be frank, it needs to be all levels. It needs to go from your receptionist down to the surgeon, because we all have human interaction. And the ability to, when somebody's being wheeled in a wheelchair, who's the one asking them their intake information? Maybe it's something simpler that they come in with COPD or something.
Sure.
Who's interviewing them, doing that intake? No different than a surgeon coming out of surgery that is talking to the family about what just happened. So I think it has to go from 0 to hero. None of us are beyond it. and to use simulation, especially if any of you out there have simulators in the hospital setting. My doctoral work for my dissertation was done in community hospital as well as an urban hospital, and providing opportunities on and off shift. So night shift needs to have 3 a.m. simulations. Don't make me as a night nurse come in at 9 o'clock and expect me to be in my element. And really looking at using those not just for disease processes, but also for systemic and structural nuances within cultures, creating that cultural humility.
Great. So now we're going to move to some questions. Thank you very much, Desiree. And I'm going to read those questions to you. I've been marking them as we go. So just bear with me for one moment. And our first question is,
enjoying it.
What's that?
I said I was hoping that they're all enjoying it, so I'm excited for our questions.
I think they are. We have approximately 8 minutes. So can you discuss intentional versus unintentional bias? Doing your job the best you can without what you know is with what you know is important. So again, can you discuss intentional versus unintentional bias?
So unintentional biases, I don't know what I don't know. So I might be treating a certain culture a certain way because that's what I was always exposed to. You see that a lot in like emergency departments. We know who our frequent flyers are and our clientele is, and that's my culture, but I don't realize when I get moved to another unit or I get diverted to a different hospital, I'm bringing that bias with me. So where it was our culture here, it's now a bias in how I'm caring on the unit. So that's one. And then intentional bias is knowing that you have that bias and not doing anything to change about it. So implicit bias unchecked is not a good place to be, because you're aware of a situation and you are choosing to say, I don't value you enough to change.
Very good. Thank you. Next question is, how can we improve cultural humility so that it leads to less implicit bias and improved access to healthcare? So how can we improve cultural humility?
I would return that question to a Socratic type of question.
Sure.
What are you doing in your facilities, your environment, to expose and explore cultures and cultural humility? It's more than a potluck lunch of everyone bring in, oh, no one's doing potluck right now, actually, but bring in your favorite dish from your island. But it's, are you highlighting, showing what has happened? Are you exploring Office of Minority Health? We have a whole division in the government with free resources for cultural linguistic appropriate services, as well as healthcare statistics of what is going on in our country. Are we accessing it? Is it part of our required mandatory education? Most of the time it's not. You know, we learn whatever we learn in school, and then when we get to wherever we're working, it's just the government required courses that we're taking. So I think it's being purposeful about implementation of culture and ethnicities within the context of your work environment.
Very good. I've got another question here that is a follow-up to a previous one. So cultural humility is a new term to this particular respondent. So cultural humility is a new term to me that I've never heard. Based on its semantic presentation, is cultural humility another version of color blindness from the critical race theory? That's a stumper.
That's a tough one. I would have to look at all the tenets of the race theory, as I've read it, seen it, heard it, but I'm not well versed in that. But I do know about the color blindness. And when we start to look at color blindness, that to me is very different than cultural humility. You must see who I am, whether it be light pigment, dark pigment, to care for me. So I don't believe you can be truly colorblind, But I do believe you can be culturally, have cultural humility, which is different. Like, okay, I see you're a Black female, but what does that mean for you? Where did you grow up? You know, one of my colleagues at Columbia University talk about this all the time. She's like, yeah, okay, yes, I'm a Black educated woman, but I grew up in an all white neighborhood. So don't ask me for a lived experience of inner city dwelling in a low socioeconomic area, because that's not what she's familiar with. So I think that's what the difference there is. Hopefully I answered that for them.
The next question is, thank you. The next question is, how can I explain standardization to my learners? So I'm going to have to try to interpret this question a little bit, but and so for the person that sent it in, I apologize, but I interpret this as, we talked about standardization, the standardization that comes through simulation. How do I explain that to the benefits of standardization to the people around me who perhaps don't work with simulation all the time?
So I think what's important to understand about when we're saying standardization, we cannot guarantee what's going to walk through your doors, whether it be related to culture or disease processes. Now, we might have DRGs that are high in congestive heart failure, obesity, and stroke. But when's the last time I saw a stroke patient? That doesn't mean we don't train and educate for stroke.
Sure.
It means that because of these things, we're going to make sure everyone in our facility has that. It's standard education, it's standard training. So I think that's how you put it into context. You take it out of whether it be culture or whatever content area and look at it across the board, because you want me to know how to take care of somebody with an acute MI, but the percentage and the chances of me caring for someone of that, because I'm part-time, might be less, but that doesn't mean you don't give me the education and the training. You prepare so that you are not unprepared.
Very good. So this one we'll have to do as a sort of a lightning round response.
Okay, sorry.
Yeah, here we go. But this will be easy. Can you share simulation ideas on this topic for undergraduate nursing students? Do you have a favorite? Let's make it real easy. Do you have a favorite simulation idea for an undergraduate nursing student? And then we're going to close.
Yes. So one of my favorites is actually with mamas. Black and brown mamas are dying. We know that. Andrew had that statistic. So when you're doing postpartum hemorrhage sim, preeclampsia, don't just make it in their background. Oh, it's an African-American woman. We know that the canned simulations that are there and available for you have that. But bring the statistic in. When you're doing asthma care for a pediatric patient, bring in that Hispanics are, I believe it's like 3.2 times as likely to experience asthma and uncontrolled asthma. Bring that into your discussion. Dig deeper than just, oh, they have asthma. What can we bring about the whole social determinant of health aspect into that sim?
Perfect. Bravo. Thank you. So we're gonna just wrap up, but to the question we were just answering, watch for our free online resources. Everyone online will be receiving an email, and we'll have other free resources coming to you, including an exclusive ebook that will be available for this audience on diversity in healthcare. So please watch for that. Please also visit our website for at laerdal.com coronavirus. Corona's spiking again. So please visit our coronavirus resource center on our website. And with that, Desiree, I want to thank you. Thank you very much for being here. It's a pleasure. It's been a lot of fun being here, and it was a lot of fun just working out what we'd present today. And I hope everybody online got a lot out of it. From the comments, it looks like people have really enjoyed it and really have been engaged. So from all of us at Laerdal, we'd like to wish everyone viewing a happy holiday season and certainly a happy new year as we go into 2021. We're privileged and humbled that you joined us today. And again, Desiree, thanks so much. Very much appreciated.
Thank you for having me. I appreciate it.
It's been a great hour. Thank you.
Okay, that concludes our presentation. Thank you again to our presenters, Andrew and Desiree, and thank you to our audience for such great questions today and for all your participation. We really appreciate it. To our audience, we value your time and feedback. Please take a moment to fill out our brief post-webinar survey so that we can provide the best feedback to our presenters and the best content and resources for you. We'd like to once again thank the sponsor of today's webinar, Laerdal Medical. And as a reminder, this webinar will be available on demand, and a link to a recording and a copy of the slides will be sent to webinar attendees within the next 48 hours. This concludes today's presentation. Thank you and have a great day.